evening, everyone, and welcome to the PHNs webinar this evening on long COVID. We have a few people still joining us tonight, but thank you to everybody who has dialed in from all across Queensland. My name is Alyssa Hatherley. I'm a GP here in North Queensland in Mackay, and very glad to be your facilitator here this evening for this topic, which is incredibly important to all of us working in general practice. I think we're looking forward to some great insights on how best to diagnose long COVID in our patients and what investigations, if any, are necessary and how best to manage these patients moving forward into what is still an evolving disease process. I'd like to first acknowledge the traditional owners of the country on which we meet tonight across Queensland as the first providers of healthcare for thousands and thousands of years in our nation. I'm joining you from the traditional country of the Yuwabara people and like to pay our respects to everyone's traditional owners and their elders past, present and emerging. I'd also in Mackay recognise the Australian South Sea Islander community as a distinct cultural group in our region. So we're talking tonight about long COVID, and we have some fabulous presenters from across the state to help us develop some more insights into the condition. Just a little bit of housekeeping first up. You will notice as an attendee tonight that you can't turn on your camera or your microphone. If you would like to contribute, particularly with questions, please use the chat function on Teams, and that will help get those questions through to the facilitators tonight. Just make your questions available for everyone to see, please. If you're having any difficulty with stability of your Teams function tonight, I understand Google Chrome and the Edge web browsers are probably the best ones to use. So if you need to leave the meeting, come back in using Google Chrome or Edge and you'll get on really well. Of course, tonight's conversation is being recorded, so we'll be able to share that with everyone down the track. If you have a question that isn't answered tonight, of course, we will take that question on notice and then feed back to you the answers as they become available. If you want to direct your question to a particular presenter tonight, that would make answering that question even easier. Now, I think we're ready to start. Our first presenter tonight is Matthew Brown. Matthew was seconded by the Chief Health Officer into the COVID response to look at long COVID and the potential implications for the Queenslanders and for the health system as a whole. His substantive role is as Director of the statewide Paediatric Health Service in Queensland Children's Hospital. And Matthew will be talking tonight about referrals to the COVID long program. So thank you very much, Matthew, for being here this evening.
Thanks, Alyssa, and hi everyone. I'm just going to share my screen, or at least try to. Let's see how we go. Now, how have we gone? Can we see my slides? Great. Thanks, folks, for the invitation. I'm going to take the liberty, being the first speaker, of doing a little bit of scene setting here. So this is essentially going to be an overview of what we know and what we don't know about long COVID. So it's about understanding it. It's going to talk a little bit about prevalence and the context in Queensland. Now, I've often likened this to trying to wrestle a column of smoke. There's much that we don't know, and it's very difficult to pin down. And there's a lot of challenges in this, and I'm sure this is familiar for a lot of people, particularly those that have heard me talk about this before. So apologies if this is familiar, but I think it's important as part of the scene setting exercise. Obviously, there's a variety of definitions. They use things like different time periods. So, for example, you read information from the CDC, they use ongoing symptoms after 4 weeks. The WHO talks about ongoing symptoms of around 12 weeks or beyond. And lots of reports use different intervals when they're reporting on this condition. There's obviously a lack of a definitive diagnosis. So there's no objective test. It's a diagnosis of exclusion to remove other possibilities. And in a WHO webinar, they were talking about there now being over 200 symptoms reported in the literature. Obviously, you've got to contend with changes to the virus. So you've got variants and subvariants. And a lot of reports you see reflect earlier, more virulent strains. You've got the impact of vaccinations. So some reports are talking about the impact of COVID and the long COVID result following it going through unvaccinated or partially vaccinated populations. And often reports talk about symptoms rather than expressing the nature of any ongoing functional impact. So the risk with that is the fact that you might be equating someone that has a lingering dry cough with someone who's so fatigued they can't return to work. Likewise, when it comes to looking at patients, you've got studies that involve hospitalised patients. You've got others that talk about people that have been cared for in the home and mixes of the two. In the former, it's often a challenge because if you've got a patient that's been ventilated in intensive care, then it would be difficult to discern whether their recovery, if it's protracted, and it probably would be, whether that's due to post-intensive care syndrome or whether it's long COVID. You've got a reliance in the literature on self-reported symptoms. Obviously, this induces a response bias. The Office of National Statistics in the UK, I'll talk a little bit about this later, but that's obviously a big study on this, and it uses self-reported symptoms. And as a result, the whole research methodology is variable and generally considered, unfortunately, to still be relatively weak. Now, I'm talking generally, there's some good stuff out there. Not only do you have to contend with things like self-reported symptoms, you've got retrospective studies that in themselves have biases with recall of experiences and events. Very few have control groups. And the more meta-analyses that come out, they do say that the higher study quality correlates with lower prevalence. So what is the prevalence? Well, is it a matter of being afraid? There's a lot of stuff out there that gives people cause for concern. And in fact, when we're talking to our consumer reference groups, we've had people say that they're more afraid of getting long COVID than they are of getting COVID. And it's not hard to see why those thoughts exist. There's tons of emotive language out there when this condition is discussed. And often they're drawing on these studies that I don't think are representative of the Australian context. So they're talking about 50 to 80% prevalence of ongoing significant conditions after 3 months. And often these reports in the media particularly are drawn from publications like those coming from the UK. And I mentioned the Office of National Statistics earlier. These offer these monthly updates. They've got a big data set currently reporting. Well, in fact, this has been superseded by the October report, which is now 2.3 million. So an increase of 300,000 since September of people self-reporting that they have long COVID. And obviously this gets picked up to create the picture that there is a very dire situation out there. But I want to go behind some of this literature and just hopefully just give some sense around what these studies say and what we need to pay attention to if we're hearing it. So in the case of the Office of National Statistics, it changed its methodology in September, moving solely to a remote method. Believe it or not, this was done face-to-face, 200,000 people face-to-face before September. And they're reporting that this remote method increases the unadjusted odds of self-reporting long COVID by 32%. And even adjusting for this, they still estimate that their odds of reporting long COVID are 30% higher. So they're acknowledging that there's a range of biases that exist here. They also acknowledge that there are a few biases that are against people reporting long COVID. And you've got other studies, some recent stuff where people are saying, at least the media are saying, finally we have an understanding of prevalence. This was a big Dutch study published on the 6th of August. It was prospective, it had a control group, had reasonable numbers, tracked a lot of symptoms, compared these with the controls, and they found that 12.7% of patients were still experiencing symptoms that they attributed to long COVID. But if you go behind the, before I do this, I'll just acknowledge the fact that this 12.7% figure was picked up, and you might have seen people talking about the estimated prevalence being 1 in 8, because that seemed to be the message that came out of this. But like a lot of things, the devil here is in the detail. So while there were a lot of positives to say for this study, it ran from March 2020 to August 2021. So most people were infected by variants that predated Omicron, obviously. And 90% of the cohort were unvaccinated. People were self-reporting their symptoms. And in our context, it's very likely that the prevalence will be less than 1 in 8. So what does this mean for Queensland from a population health perspective? I don't think there's reason for panic here. I'm taking a population health perspective here. I acknowledge the fact that the journey of some people with long COVID is a very grueling one. But if we look at some important stats, as of yesterday, 99.7% of all COVID infections in Queensland have been attributable to the Omicron variant. 93.1% of all Queenslanders are fully vaccinated, and 1.9% of all COVID infections in Queensland have been reinfections. And it's just worth noting that 1.5% of the reinfections, they're people that are up to date with their vaccinations, and 2.4% reflect those who are not up to date with their vaccinations. So while there's some emerging data here and it's still very embryonic, it does tend to suggest that there is some benefit to people being advised to be up to date with their vaccinations. There's a couple of items in the literature that are closer to the Queensland context. So this was an article from The Lancet looking at the risks of long COVID when comparing Delta versus Omicron. And they found that the odds of Omicron were, in terms of getting long COVID, obviously, were less than half of the odds after Delta. And they noted significant benefits conferred after vaccination. But of course, this also relied on self-report, and it took long COVID as ongoing symptoms 4 weeks or more after the start of acute long COVID, but they did not go as far as 12 weeks. Oops. So yes, the observation there would be that it's still likely in our context to be lower than expressed there. There's a very interesting Israeli study looking at the association between Pfizer vaccination and long COVID reports. But again, this was taken from March 2020 to November 2021, published very recently though. So obviously the variants before Omicron. Interesting study from the point of view that it looked at people who were confirmed through PCR with COVID and those that had not got COVID confirmed with PCR. And of those in the former group, obviously an unvaccinated cohort, a vaccinated cohort with 1 jab and a vaccinated cohort with 2 jabs. They compared ongoing symptoms after 12 weeks. It was self-reported symptoms, but they didn't look at functional impact. Nevertheless, the findings were interesting. They found that there was an absence of difference in symptom frequency between the people that had 2 doses of Pfizer and those that were uninfected. And they made an important observation here, and this goes to the heart of trying to discern long COVID from other contexts. They said it's commonly reported that post-acute COVID-19 symptoms are not specific to COVID-19 and are commonly reported regardless of infection status for a variety of reasons. And obviously the Pfizer vaccine may have a protective benefit against long COVID, noting it affected it was talking about the Alpha and Delta variants. So returning to our context here in Queensland, with the Department of Health role that I have, we've really looked at trying to reframe messaging and resources on long COVID here. So we've put this in the context of your COVID recovery. And as a sidebar, there's an interesting paper that came out recently looking at messaging and the importance of messaging when we talk about this in terms of either recovery or long COVID. If you talked about this in terms of recovery, this particular paper said that patients felt like their symptoms were going to be milder and shorter in duration, and they had a greater sense of control over their own health. Whereas if you used long COVID, obviously the opposite applied. They felt like their symptoms were going to be more severe, longer, and they felt like they had less control. Anyway, that came out post us making this decision, so it was just an interesting thing to see. So your COVID recovery, we've updated a lot of resourcing for clinicians and the public with some messages around the fact that everyone obviously recovers differently, that some kind of post-viral syndrome effects are not uncommon with a whole range of illnesses, including COVID. There's differences in recovery time for people, encouraging people to take their time and to ease back into their regular activities. Reconnection's important, sharing some self-management links and to see their doctor if they get worse, test if they have new symptoms, and that up-to-date vaccinations will help. And there's lots of good self-management resources that are out there. We obviously need to understand on an ongoing basis as this situation continues to unfold what the demand, the gaps, the support and opportunities look like. We've been meeting with a range of representative groups, so GPs, 13Health, 13COVID, health consumers, clinical networks. I've been talking with interstate clinics and the other jurisdictional long COVID delegates. And there's a national COVID response that's underway. People might have heard of the parliamentary inquiry into long COVID and repeated infections that's actually superseded what was happening in the background with the states getting together wanting to have a national long COVID response. So that will happen, assuming all the states get on board and agree to it, and Queensland certainly does agree to that. Importantly, we've been reaching out to our colleagues in GP world. We have a long COVID GP focus group that met back in, now it might have been July, and they advised us that at present, what they see in the Queensland context is that demand is low. The tertiary specialised services are not currently required. It can currently be managed in primary care, but there is a need to improve access to community allied health for support. And one of the things that's worth noting is as we see this situation continue to develop, and talking to colleagues in other jurisdictions, particularly as the Omicron cohort comes through, a lot of long COVID work that they're doing, they are acknowledging that their cohorts are getting better with time. But we're not resting on our laurels. We need to understand this and keep trying to stay on top of it as it continues. There's a number of ways in which we're trying to do this. There are 3 noteworthy surveys. There has been a survey run by Metro South HHS of GPs in Brisbane South PHN looking at long COVID presentations. I'm not entirely sure whether that has wrapped up. When I spoke to the Metro South delegate running it, it was underway, but I think they were struggling to get numbers in. In the department, we've just run a very large survey of about 30,000, a text-based survey to 30,000 people with a response rate of about 25%. We looked at people that had tested positive to COVID and flu 3 months ago, COVID or flu 3 months ago, and those that had tests and were negative to both of those 3 months ago. And we asked them a series of questions based on the post-COVID functional status tool of ongoing symptoms and functional impairment using the Whisper communications platform. Now, we're yet to really have a good look at the data on that. That hasn't been closed that long. And I'm happy to report when we have something that is that we have in terms of our outcomes. And the COVAX group has been following up with people who had their jab, their second vaccination 12 months ago. And where they acknowledge they've had COVID, they ask them a series of post-COVID symptom questions aligned to the EQ5D. But so far, we're not seeing anything like what is reported in the media at the population level, acknowledging that some individual stories are not great. But at the population level, we do not see anything like what gets generally reported for overseas particularly. And I would just flag some caution as a result with the overseas comparisons, and sometimes with even the Australian pilot clinics, whose context compared to Queensland is very, very different. And some of the methods of reaching out to former patients might induce some different context to the information that they're seeing as well. And that said, there's some really good resources that are out there. I'm mindful that this is going to go to people, so I'm happy to share the presentation. These are all active, as far as I know, they're active links. So a range of good overviews. New South Wales does some fantastic stuff. They update it regularly. There's some good screening tools, some good clinical advice and management guides that people probably are already aware of, but there's some additional ones there, hopefully, if not, and some self-management tools. That's it for me, and I'm mindful that we're going to have a panel at the end, so I won't throw over for questions, but I'll be here for when the questions do come in.
Thanks so much, Matthew. Really appreciate all of those insights, and it's really good to know that whilst we're wrestling smoke, it's not quite as much smoke as we had initially anticipated. So we'll head on next to our second presenter this evening, Dr. Rodney Pearce, who's a practicing GP in South Australia. We've managed to get the time difference right tonight. Rodney has held a number of leadership positions in health, both nationally and in the greater Asia Pacific region, looking at influenza and having worked with ATAGI previously. So we're really glad to have Rod here tonight with us to talk about the national and then global early perspective on long COVID. Rodney, thanks so much for being with us.
Thank you. It's a great opportunity, and thank you for that Queensland perspective, because one of the things I was conscious of is someone from outside trying to tell you what you might be doing. So I left that blank in my presentation. So hopefully my presentation is now up on screen. Can you just confirm that, thanks?
Yep, it's there.
Cool, thank you very much. Thank you. So trying to piece together, as Matthew was saying, what's happening around the country, what's the best way to approach it, and then because I work as a general practitioner, trying to see how it's actually going to affect us as GPs. So I've tried to just put it in context and remind ourselves what's happened with previous pandemics, look at broadly what fear factors, as Matthew says, might be looking nationally and internationally, look at some of the thoughts that are happening, and I've taken 3 states just as an example, and then what's happening we think locally when we've talked around the country as a chaired immunisation coalition. A lot of the doctors in the coalition are actually working in long COVID clinics, and then rounded up with a little bit of work that as a clinician, as a GP, what it is that we're actually faced with. And this is just a reminder that in the 1918-20 influenza, post the pandemic, came these terms about tiredness and lethargy. And a lot of the time associated with it, people talked about the fatigue, the anxiety, the depression and neuralgia. So again, those have been practicing in the last 20 or 30 years have been wondering where chronic fatigue fits. It was originally called a post-infection fatigue, and a lot of diseases that we've seen are talking about, is it actually brucellosis that causes this chronic fatigue? Is it Q fever? Is it Giardia? Is it glandular fever? And most of us have struggled to find an absolute relationship, and then the current theory says that after an infection, it's probably a combination of a particular virus, but also how the host responds. And so we've actually got to remind ourselves is that each person's an individual, how the disease actually affects them. You can have a population study, but it's the individual we're actually trying to deal with, particularly in general practice. When someone presents, it's what's happening to them. Doesn't matter what thousands of people overseas might be happening. And just a reminder that there was a disease that was actually ultimately fatal called subacute sclerosing panencephalitis, which was a long-term consequence of the encephalitis associated with measles. So we've got previous historic examples of over 150 years where when we have an infection travelling around the world, there's a whole lot of diseases that are following from it. And again, I think Matthew's kind of reminded us that if there's 500 million cases of COVID, then is there 100 million long COVID cases? And doing some work in the Asia Pacific, we heard of some of the Indian experiences where they thought that COVID was really nasty and that long COVID was maybe up to 50%, and we thought that was because they're under-reporting it. And then I think it was Taiwan and Korea were saying that it might be less than 5%, and then we wondered what that meant, or were they somehow handling it differently, or was there a different ethnic effect, or was it some genetic effect? So again, it's the host, maybe it's the variety of COVID we've got. WHO definitions we've talked about broadly, and that's been the common things seem to be the effect on the lungs, the tiredness, and then the brain fog or cognitive symptoms. Most people talk about lasting more than 3 months, but you see in Australia some of the long COVID starts as people are getting out of the acute phase. And probably the common thing that we should try to remember is that we need to associate it actually with an infection. So some of these, the post-COVID could imitate something else, but if it's actually occurring within the 2 weeks following the infection, then I think most people feel comfortable actually attributing to it. And there's a few sort of interesting things that people notice, particularly when we first heard about the smell and the taste, and sometimes the GI effects, the pain, paresthesia, headaches, and the psychological effects. So already been alluded to, if you want to make a submission to the House Committee, Mark Butler set this up, and so there's an opportunity to present anyone's finding. General agreement that it's not a single disease, there's no single test, there's no unifying pathophysiology, and generally as again, I think Matthew's pointed out, is most people think it can be managed in the community. That doesn't mean it's easy. There's a question about what resources we've got in the community to manage it, and I think that's going to be our biggest challenge. Even though there's not 100% agreement, most of us know there's going to be a challenge to look after it where it should be managed in the community, and what resources to actually do first, well, with assessment and then long-term management. The Queensland, fortunately, left blank. I didn't want to appear to be an expert. I've left the other West Australia, Tasmania, ACT, Northern Territory blank because there's always slightly different. But I thought it was interesting that New South Wales were coming in fairly early. They were saying if it was 4 weeks after the positive test, they were starting to get interested. In Victoria, it was established very early as a follow-on from the respiratory COVID clinic. So when people were in hospital and then they were being followed by the respiratory physicians, then they were using the physicians associated with the respiratory unit, but they also had important liaisons with everyone in the team, the general practitioner and the psychiatrist, very important both for the staff and for the patients. South Australia's got a slightly broader version of what long COVID is, setting up some centres based at the Royal Adelaide Hospital or some of the larger centres, and essentially if it's associated with COVID and it's not resolved within 12 weeks. And the other states, I think, have versions of the same, and you can talk about them, but I thought having the Queensland insight was really useful to me, and it's going to help with some of the things we'll do in South Australia. And I think we're all trying to learn from each other and follow it as things are evolving. So when I'm talking local, one of the challenges we've got is where do you actually go for your help? And one of the things that we're finding is a real challenge is it's not quite as bleak as who has to pay, but a lot of the time it comes to where are the opportunities for the patients to get their support, and it's often where the resources are. So it's going to be important to actually work out, are you getting some local, maybe from your health network, or is the state going to pay for it? The patient may look at some private health options, but they're fairly limited. DVA is fairly broad in its support. There's some potential for compensation to be caught up in this. So if you get COVID at work, and might just got a patient I'm looking after who went in for his plastic surgery and caught COVID while he's in for that. Is he going to try to sue the hospital for getting that? What happens if you fall asleep at the wheel? Is that going to be some sort of compensation? I think the local health network is going to be particularly important. In the rural regions, we're finding that we're trying to put our resources through that local health network. But again, how do you actually get that to the coalface is a stretch of our current resources. The state health systems, I think, are using their big hospitals as a way of channeling resources, but there's a limit to what outpatients can offer and how much can be moved into the community. And those of us who saw the benefit of the COVID referrals with a mental health care plan have been reaching out and asking for some Medicare support. And a lot of us think that if there's a Medicare item number, both for the time that a GP or provider actually spends with a patient who's got long COVID, and can we get an extension of the healthcare referrals maybe for the next year or so, where that could be COVID appropriate. Obviously, concern seeing the last week or so, apparently Medicare is being ripped off to billions of dollars. There's going to be some concern about actually getting long COVID care through that scheme. And then whether the primary healthcare networks are going to be the way that the Commonwealth might actually distribute some of their funds. And from an individual clinician point of view, someone who comes to see us, is the presentations are so variable. As Matthew said, there's some 200 different associations. And the thing that seems to be in common is that patients will tell us that they're not getting better. The overlying psychological issues are an important question. And are they secondary to the original illness? Were they the dominant factor? And in the end, they still need support. You need to exclude worsening of a pre-existing illness. So someone with chronic airways disease, diabetic, someone who's had a previous stroke, you need to make sure that you haven't got that exacerbation, and it may be that is worse. And all of the data on the all-cause mortality has told us that there's probably something happening there. A lot of diseases are worse after people had COVID. Increasingly, people are confident we need some baseline assessment of someone's function. And so whether it's a specific allied health referral for an assessment, and in South Australia we've got some 10 or 20 different baseline assessments assessing some respiratory or psychological baseline, whether it's a depression scale. And the purpose of that is to be able to say to someone, this is what you were like when you started, and then you can say, we seem to be improving. And like I said, look at a particular intervention that fits with their presentation. Say they can't exercise, they can't walk, they can't go to work. And then if you can say, right, you can work 2 hours a day, and then you've got a baseline, and then you can improve it. And then monitoring the progress remains really important. So establishing a baseline and excluding any other disease. And in South Australia, it's tending to come out of 3 baselines, where people who've survived the acute infection, they've got some contact with the hospital, they've got specific disease that is related to that, and everyone can see that they're otherwise healthy, and then they've had COVID. There's the exacerbation of pre-existing illness, and then where somebody actually gets COVID, and then after it, they've got all of these symptoms, and it's a question of how come COVID, which seems so mild, can end up with somebody who hasn't worked for 6 months, or they can't sleep, or they've got pain that we can't explain. And it's a disease of exclusion. We need to make sure they don't have anything else, and that's one of the challenges in primary care, is that we actually need to rule out the other diseases. And I guess in general practice in primary care, that's our core business. Someone comes in, presents with a headache. Is it a brain tumour, or is it just the stress or a new family? And that's a very important challenge to work out how much to investigate, not to over-investigate. So validating symptoms, talking to people, saying to them, yes, I understand that you've got these symptoms, is I think a way of actually managing and calming down the response, which fits, I think, with what Matthew was saying. You need to rule out, but be careful not to over-investigate. And that's a real challenge when a patient is saying, I'm not sure what's wrong. You know, maybe I've got myocarditis, maybe I've got this, maybe I've got that, maybe I've had a stroke. And the temptation to keep on running test after test after test. And again, that's a common thing in general practice, where an anxious patient will come in, tell you they've got all these things wrong, they've got to see 30 specialists. And managing that is a challenge, and to do that and keep it in perspective, but not to miss anything that could be explained. And all of us have thought we found a psychological condition, and then found a physical cause underneath, and we're all being careful, but find that balance. Reassuring the patients that probably everyone improves. It can take time. They're robots. Sometimes they're just organisational, or the way the system is set up, but recovery can occur. And I think that's, again, fitting with what Matthew's saying. And remind people that you need to have graded activity, that you need to increase it. And one of the interesting side effects I know from Victoria was that they were saying high achievers, or people in the healthcare sector, are used to doing a lot, helping people. When they get affected by this, they're really impatient, wonder why they can't work. So someone who normally worked 12 hours in a shift in a hospital suddenly wonders why they get tired. Just remind them that they are allowed to slow down and actually be more normal and recover slowly and appropriately. But reassuring people that they will get better seems to be really, really useful. And then help people actually managing their own frustrations, and so that it doesn't become a post-traumatic stress situation. They feel that they're not doing the right thing. And occasionally there's going to be situations where a particular subplot of where they're going, or an exacerbation, will mean they need further specialist management. So thank you very much. But lots of things are happening. It's still a challenge to bring it into a context, and it's important, how do we actually manage it from an individual clinician's point of view. So thank you very much.
Oh, thanks, Rod. That was really appreciated. Certainly for myself, I don't think I have COVID according to the RAT, but I'm a little bit under the weather, and being reminded that taking time off is important as a healthcare professional is something that we need to hear often, isn't it?
Yes, it is.
Now, our next speaker tonight is Graham Exelby, who's one of the GPs from Mermaid Beach on the Gold Coast. He's going to be talking about some work with molecular biologist Dr. Valerio Bertoni, looking at the DNA mutations possibly underpinning long COVID. So this is really exciting information, utilising some of the work coming out of Griffith University, looking at decoding the DNA in long COVID. Thank you very much for joining us, Graham.
Oh, thank you. Thank you very much, Alyssa. I'm glad to be here. A little bit of background. I hope you're hearing me. 15 years ago, my life in medicine changed completely because I had to confront POTS in one of my family following a very simple operation. So, unable to work, I acted first in a support role, and then as my colleagues simply had no explanation for it or how to treat it, my second role looking into the research into POTS was launched, and 400 POTS and untold fibromyalgia migraine patients later, the ability to work out the underlying causes and gradually improving ways of managing POTS gave me a head start when COVID started to produce POTS and its victims. This is not about POTS. I must say GPs are the logical people to deal with the complexities of long COVID, as the problems cross many specialty areas. And in rural areas where I imagine most of the people are tonight, it will be the poor GPs who will have to carry the burden. Unfortunately, the current guidelines we are offered from WHO, from our government, our RACGP, are simply dreadful. To be blunt, long COVID's various forms can usually be treated often very quickly, cheaply and easily. First slide. Yeah. That's an interesting man. There was a chance meeting a year ago with Dr. Valerio Bertoni, a molecular biologist, after he had a surf injury at Mermaid, that opened the door to working out the underlying DNA mutations in long COVID, as well as POTS, fibro and other complex problems. And with the DNA findings and existing research into POTS, we found that most long COVID can be successfully treated. Valeria and I wish to share our findings. This is too big for just small practice on the coast. The DNA studies we've been trying to do have been delayed by an inability to secure funding for the larger studies to examine the various long COVID subtypes we've found, as we've been completely dependent on our patients self-funding these. Valerio uses a technique called genetic imputation, utilising the 750,000 SNPs on a chip in a sequencing machine in Germany. He uses this information to predict with over 99% accuracy the patient's genetic variances. Once this process is completed, the variances are then further analysed against 83 million additional SNP variants. These findings make it possible to recover most patients if they're not too badly damaged by the inflammatory and microembolic cascades so typical of a SARS infection. Can we go to the next slide? First, and arguably the most important when looking at recovering long COVID, there are mutations in mast cell function that Valerio has discovered, one on the membrane and the additional mutations of two critical enzymes, the DAO enzyme and the histamine N methyltransferase. I've got to read that off the slide. Which is involved in clearing histamines in different tissues of the body. Good. This is a tricky slide. Tricky for me, as I tend to leave it to Valerio if I have to go to DNA to work out the best way to tackle the patient with these mutations. These are not simple. But for us, and certainly for me in general practice, adequate histamine blockade and low histamine diet is usually adequate to counter most of the long COVID symptoms. After this, there are various COMT mutations with their reduced ability to process catecholamines, and this is a critical mutation in POTS and POTS like COVID. COMT mutation gene production is itself influenced by methylation, and in the presence of SAMe, a product of the methylation cycle, which is in turn affected by multiple mutations. Some very common, such as the MTHFR genes, which naturopaths have a field day with, and patients are frequently unnecessarily scared. This is not a scary mutation. So there's an association, unfortunately, between COMT mutations with malignancy, especially breast cancer, and also endometriosis and autoimmune disease. Then there are various oxidative stress and inflammatory mutations. Most of these mutations are amenable to epigenetic modification. I hope I have all of this right. This next part is the researchers are speaking after me. The heroes for a lot of the long COVID work is Griffith University. So from them, natural killer cells distinguish malignant from healthy cells, while type 1 and type 3 interferons are innate cytokines important to the first-line defense against SARS. The mutations found at Griffith, the TRP mutations, affect natural killer cell function. And complicating this, SARS has evolved mechanisms to evade the antiviral function of interferon 1, and SARS patients show limited interferon 1 responses, while there's an increased expression of IL-6, tissue necrosis factor alpha, and other chemokines. Possible implications of this are in an increased malignancy rate and severity of malignancy at presentation following SARS infections. There are no published figures on post-COVID malignancy, but it is a significant population in my long cohort group, mostly lymphoma, adenocarcinoma of lung, melanoma, and breast cancer. Next slide. We're starting to get into the nitty-gritty. This is the glymphatic system, which was discovered in 2013. It's basically the sewer of the brain. Dysfunction and obstruction to its flow is a major part of this new work, not only in brain fog, in POTS and long COVID, but also in migraine, Parkinson's, and Alzheimer's disease. I cannot wait to see what Griffith brings up in the future. The mutations they've found affect lymphatic function with a consequent reduced clearance of waste solutes from the brain, causing fatigue and brain fog. Low-dose naltrexone is a H4 blocker and provides a therapeutic benefit here, but it's not a universal panacea, and at times it's hard to use. The glymphatic system is thought to play a central role in macroscopic distribution of lipids in the brain, and that lipid-soluble molecules require carrier particles in order to be delivered via the CSF. Astrocytes play a key role in lipid synthesis and distribution by releasing lipid carrier proteins such as apolipoprotein E, and in maintaining the highway for distribution, which is the glymphatic system. Thus, ApoE4 mutation is yet another important mutation. It's a major genetic risk factor for Alzheimer's, as this lipid carrier is important for maintaining the homeostasis necessary for a healthy environment of the brain. Briefly, this mutation is seen in around 15 to 20% of the general population, with 2 to 3% being homozygous. These have a 15% increased dementia risk, but this mutation also affects arteries and significantly increasing coronary artery disease. It decreases mitochondrial function, it decreases insulin sensitivity, it increases insulin resistance, it causes fatty liver and progression to cirrhosis. The next slide. So what's this got to do with it? The lymphatic systems in the brain and eye export fluid and solutes from metabolically active neural tissue and drain via the cervical lymph vessels, which empty into the venous system at the level of the subclavian veins. There are two potential sites of physical obstruction which we are looking at and trying to measure the impact of, which are along the jugular vein and at the thoracic outlet. And the latter appears to be responsible for at least some of the symptoms attributed to the very controversial thoracic outlet syndrome. Intriguingly, the lymphatic system functions during sleep and largely disengaged when you're awake. The biological need for sleep may therefore reflect the need that the brain must enter a state of inactivity to enable the elimination of potentially neurotoxic waste products, including beta amyloid, which I bring up here because it is integrated into the fibrin clots that comes with COVID. Not in all. Unfortunately, we don't have any way of measuring that at the moment, but apparently that's underway. Next slide. This is from an optometrist. It shows a retinal photo showing arterial plaque. Unfortunately, I can't put a pointer on it, but these very high level retinal photos will show things like craniovascular pressure change, but this one shows plaque in her retinal arteries, and she is severely incapacitated. She has COVID, and then she now has a very severe form of POT. So back to the infections and transition to long COVID. Once inside the cells, the SARS virus interacts with toll-like receptors, TLRs, with the resultant cytokine storm, especially involving IL-6 and tissue necrosis factor alpha. Next slide. This is a fairly important slide. This was put together by Valerio for a meeting of a group we put together as a long COVID task force on the coast. It shows the disease-associated TLRs and the drug targets that work on these, and that's with famotidine and low-dose naltrexone. It also shows the potential malignancies that are associated with the same TLRs and their putative molecular pathways. The hyperinflammatory cytokine storms cause far more morbidity and more mortality than any direct viral cytotoxicity. And with the inflammatory response comes the cascades of microemboli in some patients, and some of these have amyloid. There's a researcher called Muddergy found that the venous emboli are a result of histamine receptor H1 induced fibrinogen. I want to go very quickly to cardiovascular risks with COVID, as we as GPs need to be aware of these. Acute SARS is associated with a 6-fold increase in cardiovascular diagnoses. These decline from 4 to 12 weeks after the acute infection and return to baseline generally between 12 weeks and a year after the infection. But the risk is magnified in the over 65s and in patients with more severe disease. But the risks are more evident if those who are smokers, who are obese, with hypertension, diabetes, chronic kidney disease, hyperlipidemia, and pre-existing cardiovascular disease, as we all know from the statistics on death rate. But the risk of cardiovascular disease doubles in people who've had 2 infections and tripled in those who've had 3. These numbers translate into 50 extra cases of heart disease per 1,000 who've had COVID twice. So what's happening? Mast cell histamine in COVID is a regulator of pro-inflammatory fibrotic and thrombogenic processes and exerts its biological actions through 4 types of histamine receptors, H1, 2, 3, 4. In the immune system, histamine is mainly stored in cytoplasmic granules of mast cells and basophils and is released upon triggering along with other mediators such as serotonin and tryptase. Brain inflammation plays a critical role in the pathophysiology of brain diseases, and inflammatory microglial activation from IL-6 and tissue necrosis factor alpha is the most common pathology found. It is the brain mast cells rather than the microglia which are the first responders. Most importantly, the activation of the mast cells is shown to activate the microglia, whereas stabilization of mast cells inhibits the CNS inflammation that would otherwise result from activation of the microglia. The microglial activation causes small fiber neuropathy and neuropathic pain. And from this small fiber neuropathy, it's believed comes the sensitization and characteristic autonomic chaos that is POTS and POTS-like long COVID. It also accounts for random symptoms such as the eye pain and anosmia. Can we go to management? Next slide. I'm going to restrict myself to the 2 main ones. There's a lot of detail on information I have available for anyone, but let's keep to these 2. Fatigue is the most common symptom in long COVID, often totally incapacitating. The mitochondria are the energy sources of our cells, and COVID affects the mitochondria. And when your mitochondria are dysfunctional, it's associated with defective immunological response to viruses and chronic inflammation. COVID reactivates other viruses, especially EBV viruses that are resident and still affect mitochondrial function. It's not only that, it's not just the mitochondrial dysfunction, it can also be from direct inflammatory or embolic damage to the heart, kidneys, liver, brain, lungs. And there's also the oxidative stress that's part of this. And it can also be the impaired autonomic function from the IL-6 and TNF-A-driven small fiber neuropathy that affects heart function and microglial damage in the brain. Let's move to the next. Okay. Cognitive impairment or brain fog is common, just as it is in POTS, fibromyalgia and migraine. Lymphatic flow is very important where fatigue and cognitive impairment are present. Complicating this, variability in brain fog can be impaired, as shown in craniovascular perfusion studies described in Adelaide in 2020. The red flags, these are the ones that you'll watch for. A reminder, firstly, that a deterioration in symptoms may reflect a new COVID or other infection. All of these patients have to be patiently sorted out to have any hope of correcting the problems we're seeing. Unfortunately, successful time on COVID management is very time consuming. For me, with a POTS-like one, it takes me a couple of hours. Simpler ones, maybe about 3/4 of an hour. Next slide. Medication starts with the control of the inflammatory process. It controls the central sensitization from the microglial inflammation. I've got 100 people in the long COVID clinic, and this has been the end result. So firstly, I test tryptase, high sensitivity CRP, ANA, complement C3 and 4, full blood count, biochemistry, and D-dimer, and other things depending on the history. Then I proceed to H1, H2 blockade. I usually start with that's Telfast or in the Zyrtec. Then famotidine 40 BD for those of us who are older. We used to use this quite a lot in the 80s. If gut symptoms are significant, you can replace the famotidine with nizatidine. My next step after about 4 weeks is H4, histamine 4 blockade with low-dose naltrexone, which improves both lymphatic and natural killer cell function. A caution, if the H1, H2 blockade is not tolerated, caution with LDN. LDN needs to be started at a low dose. I normally use 0.5 of a milligram daily, increasing weekly to a maximum of 4.5. But my overall impression is the TLR3 blockade with famotidine that provides the best results. Fortunately, this is very cheap. Complementing medication is psychological support. Secondly, you have to have a progressive return to physical activity and exercise. Deconditioning makes this worse. Recommendations suggest 6 to 8 weeks post-infection. Ideally, an exercise physiologist, but for you guys in the bush, it's loads on you. I use a lot of Kiko Matsumoto acupuncture, which assists controlling autonomic instability. Next slide. Mitochondrial dysfunction is largely responsible for the fatigue and cognitive impairment, low energy and memory loss. The most effective things I've seen have been keto, low histamine diet. That's important if the HNMT and DAO enzyme defects are found if we do look at the DNA. NAD+, another favourite of the naturopaths, and NMN certainly seem to help this function. But when you're stuck and when you're trying to assess the metabolic damage, you might have to think about DNA analysis. It does provide clarity on the mitochondrial and inflammatory gene variants. And for the ones that I can't recover easily, I direct them towards DNA testing. There are red flags here too. Okay. Firstly, the lack of response within 4 weeks of mast cell blockade. Most of my patients recover within 4 weeks. Look for other factors. The most common, they can't cope with a low histamine keto diet, and look for autonomic instability. If you think you're getting POTS, do lying and standing ECGs. Do a NASA lean test. These are easy in the surgery. If you have POTS, there are mechanical drivers that underpin it, and those things are available if you wish to check on the website when it's up and running. D-dimer is one of my critical things that I watch. And if you're watching a D-dimer that won't settle, check for the inflammatory problems elsewhere driving this. Occult malignancy, sustained stress, autoimmune diseases, diabetes, insulin resistance, and fatty liver. The details on these protocols I've rushed through. They're freely available through PHN Gold Coast, and then in the next couple of weeks available on the website where we'll be putting any changes. And any GPs who are keen to learn the processes are welcome to accompany me in clinic. Thank you very much for listening to a very complex problem.
No, thank you, Graham. You've helped to make it incredibly clear, and you've given us some strategies to help our patients moving forward. Thank you so much. Next on the agenda, we have Dr. Kieran Thakalia and Dr. Natalie Eaton-Fitch, who are with Sonia Marshall Gradzink's group at Griffith University, researching to find a treatment for long COVID, having proven that the illness shares so many biological impairments, as Graham's already outlined, with myalgic encephalomyelitis or chronic fatigue syndrome. They'll be giving us some ideas about how the clinical and biological overlap works, helping with some research and diagnostic possibilities for us to look at with our patients moving forward. Thank you so much, Kieran and Madeline.
Sorry, I just realised I was on mute. Thank you for having us. I will start the presentation today. Apologies, Sonia can't be with us. She's dealing with some family emergencies, but any questions that you have that might be specific to Sonia that Kieran or I can't answer, you're more than welcome to send them through by email. But to provide background, we are a research group, Griffith University on the Gold Coast, and we've spent, well, not me personally, but the lab has spent the last 10 or so years researching the pathomechanism of myalgic encephalomyelitis chronic fatigue syndrome, or ME/CFS. Given the significant overlap between ME/CFS and long COVID, we've essentially been given a decade head start, which has assisted our research quite a bit, and hopefully we can now learn from past research mistakes and such going forward. So, to provide a background, ME/CFS is hallmarked by this post-exertional neuroimmune exhaustion or post-exertional fatigue and worsening of all symptoms that are multisystemic. So they're neurological, immune, endocrine, autonomic manifestations and such. So they affect essentially the entire body. It goes far beyond the name of the illness of chronic fatigue, if you will. There's a clinical spectrum from very mild to very severe. Severe cases are highly disabling. They are 25% of the ME/CFS population, and they're typically bedbound or wheelchair-bound even. So ME/CFS affects approximately 24 million people worldwide, or 200,000 Australians, for example. There's no diagnostic test or laboratory-based test. It's all diagnosed through clinical criteria, and there's no evidence-based treatment. Interestingly enough, 70% of patients report a post-infectious onset, and COVID-19 is believed to be a potential trigger for ME/CFS as well. So, as mentioned in the previous presentation, you have disturbances in natural killer cells. So they are more predominantly a reduction in natural killer cell cytotoxicity, so the ability for NK cells to eliminate viral infected cells or malignant cells, for example. But there's also changes in natural killer cell cytokine profiles, subsets, and phosphorylation of protein kinases upon activation, for example. But the reduction in cytotoxicity correlates with both clinical severity and longitudinally as well. So NK cells, through decades of research, have proven to be a very suitable model for studying the pathology of ME/CFS, and we use isolated NK cells from patients in the lab, both ME/CFS and COVID. So the exhaustion of NK cells as well as T cells are believed to play a role in the recovery of COVID-19 and is associated with more severe outcomes for patients and persist into long COVID. There's research in autoimmunity, but there's also research in this cell exhaustion. So there's not enough evidence to suggest that ME/CFS is an autoimmune response, but this NK cell exhaustion is very prevalent in the research. But the NK cells require calcium to regulate activity, much like many other cells throughout the body, which brings us to these TRP ion channels that were also introduced in the previous presentation. And we look at different members of the family of these TRP ion channels. There's heaps of them, but we look at the melastatin family most of all. But they are expressed in every cell type, and they respond to a series of threats or stressors, if you will, including changes in osmotic pressure, stress, changes in temperature, and exposure to infection, irritants, chemicals, and such. Infection being a key word in this case anyway. So most are non-selective, but they tend to be highly permeable to calcium. So they allow calcium in and out of cells. And they are predominantly involved in like heat and pain perception and inflammation. But the expression of this TRPM3 that we look at specifically corresponds to areas of the body where patients report symptoms of ME/CFS and as well as long COVID. So in the lab, we're able to look at the function of this channel in isolated cells from patients using pharmacomodulators such as pregnenolone sulfate and onanetin. So based off of previous single nucleotide polymorphism analysis, we had the hypothesis of whether or not NK cells of ME patients had impaired TRPM3 ion channel function, and we did this with a couple of techniques. And I understand these slides might be a little bit confusing, so don't worry too much, but essentially I want you to have a look at the shape here for the healthy control graph, see how you have a response here. So the channel is being activated. However, this is flat for an ME/CFS patient. So the activation of TRPM3 in cells in ME/CFS patients is significantly reduced when compared to that of a healthy control. When you also look at whether or not these channels can be modulated by blocking them, the response remains flat. And here you can see in these red lines that there's a reduction in the current and the reduction in activity, which means that the channels are being successfully blocked with pharmacological intervention, but they're not being successfully blocked here in ME/CFS patients. So TRPM3 on NK cells are resistant to regulation, if you will. When we have a look at the influx of calcium specifically in these cell types, it's also flat and reduced in patients through this channel. So you have a nice curve here for healthy controls, a nice response for TRPM3, whereas that response is flat. So I've sort of breezed through those slides there, but it provides a background of the research that we've been doing in ME/CFS and how it can potentially provide a biomarker or something to investigate the pathomechanism of illness, but it also provides a pharmacotherapeutic target for ME/CFS patients. And don't worry too much about the details here, but TRPM3 upon activation can result in cell activity, such as the NK cell cytotoxicity and cytokine production and such. But we're able to indirectly modulate TRPM3 activity through what's called this mu opioid receptor. And upon the inhibition or blocking of this mu opioid receptor using low dose naltrexone, we're able to restore TRPM3 function, if you will. So just remembering previously, the graphs that we had were flat. They were flattened responses. Whereas now when you incubate isolated natural killer cells with naltrexone, we see a response. And we first wanted to do this in the lab without moving on through looking at this in patients, for example. So if you have a look in this graph here, you've got a control response before treating isolated cells with LDN, and then the response after treatment with LDN. So there's a significant increase in the function of TRPM3. And then there's no longer a significant difference between healthy controls and ME/CFS patients here. So we were able to restore the function of TRPM3 in the lab. We also looked at the restoration of this calcium influx into cells, and that was also restored. Again, you've got that nice response in healthy controls, but you've also got a high response in ME/CFS patients. When looking at the function of this ion channel in ME/CFS patients taking LDN, there was no significant differences with healthy controls. So you're able to replicate essentially what we've seen in the lab in patients as well. So the activity of TRPM3 has been restored in these patients, and then these patients also report improvement in their fatigue, cognition, and pain. So given the significant overlap with ME/CFS, we wanted to determine whether or not patients with long COVID had this same TRPM3 ion channel dysfunction. And we've already heard about the different definitions and such. The World Health Organization is one definition for post-COVID-19 condition. And of course, we've heard about the differences in prevalence depending as to the study and depending as to the duration and severity and vaccination of symptoms. But what's important is that they resemble closely to ME/CFS patients. So we've been collecting data from numerous patients with long COVID, and many of those patients will in fact meet the diagnostic criteria for ME/CFS. So we are, well, challenged, if you will, by the question as to, is this patient someone with long COVID, or is this patient someone with ME/CFS? Are they different or are they the same? And that's essentially what we have been trying to do in the lab. So using the same techniques and looking at ion channel function, where we reported that the TRPM3 ion channel function was the same in long COVID and ME/CFS patients. So it's significantly impaired when compared with healthy controls. So the impaired TRPM3 function that we've been reporting, again, potentially provides a biomarker for long COVID or a treatment target for long COVID in addition to ME/CFS. We were also able to restore the modulation through the inhibition of the channel, so we can have successful activation and blocking of the channel activity in natural killer cells. So now the next step is to have a look at what this does for the natural killer cell function. LDN has been reported to improve natural killer cell function. So now we're also looking at other ways that this might work. Again, what was mentioned previously is that LDN might not be universal or might not be suitable for all patients. So we are looking at different options. The communication between the mu-opioid receptor and TRP channels is well researched, and there are other pharmacotherapeutic agents out there that will work with the same pathway. So that's something that we are looking into further. But essentially, as an overview, I know I've gone through this very quickly given the time, but we've got reduced natural killer cell cytotoxicity as a key immunological feature, and there's a significant in calcium in cells. So calcium is important, again, for regulating cell function. So reduced calcium means impaired cell function. You've got changes in TRPM3 surface expression as well as loss of function, which identifies TRPM3 in the pathomechanism of ME/CFS and now long COVID, and as a potential therapeutic target. So I would now like to hand it over to my colleague, Kieran. You might be able to actually take control.
I'm on mute, sorry. Yeah, I have requested for a control. Yeah.
There you go, give that a go.
Okay, I'm just checking the slides, whether I can get a control or not. I can't move the slides. I think Natalie, you have to help me with that.
How's that?
Okay. Oh, it's very slow, I guess, because of. Can you go to the first slides, Nat? Yeah. Sounds good. Can you hear me? Everyone, can you hear me? Oh, thanks. Yes, now I'll be presenting mostly on the MRI study, and that has been done within our center using 3T as well as the 7T MRI. So yes, so let's look at our first results. Nat, can you go first slide? Okay, so here what we did, we acquired the data, MRI data from 43 ME/CFS patients and 27 healthy control. And we try to use the different MRI techniques that is called the T1 over T2 signal intensity. We estimated that in the 43 ME/CFS patients and 27 healthy control. And we try to calculate the different brain regions, signal intensity. And we found that T1 over T2 signal intensity was higher in ME/CFS patients compared to the healthy control in different brain regions, including white matter as well as gray matter regions. For example, corticospinal tract, which is the brainstem regions, and deep cortical regions, putamen and pallidum. So if you look at in the COVID patients, so there is a this is a single case for individual COVID patients. They have also found higher signal intensity in occipital lobe as well as in the some of the white matter regions. So this indicates that if we look at the both COVID-19 patients as well as the ME/CFS patients, they are showing the higher signal intensity in the MRI study. Now, if you look at the further, next slide. Next slide, Nat. Yes, so in another study, we use the different MRI techniques. That is called the diffusion tensor imaging. Previous slide, please.
I think we have a little bit of lag, Kieran.
Okay. Okay.
Just bear with us.
Sorry for the technical issue. So in another study, we use we again apply different MRI techniques called the diffusion tensor imaging method, and we want to study like how is the axonal integrity or axonal is there any axonal loss or axonal integrity in the ME/CFS patients, or is there any change of the myelination or iron content in the ME/CFS patients? Then we found that again here we found that mean axial diffusivity and the mean diffusivity was pretty much lower in the pons region of the brain stem. And if we look at the brain function of the brain stem, this is the main brain region that controls for the movement, even for the function, and it is involved with the cardiorespiratory system, that which I think the previous speaker has been talking about. This is the main symptoms of the breathing difficulties in the long COVID patients. So we feel like, okay, brainstem might be the key regions that we have seen in the ME/CFS method, could be the another biomarker for the long COVID. And another COVID-19 study, they have shown again the similar to the our finding, like axial diffusivity in the left and the mean diffusivity at the right was significantly lower again in the white matter in the COVID-19 patients. So this study also, this and the technique using the MRI also showing that there is a similar kind of changes in the MRI in ME/CFS as well as the COVID-19 patients. Another slide. Yes, so if you look at this one now, here what we did is, okay, we have previous speaker are saying that ME/CFS, long COVID patients have neurological symptoms. So, and we know that hippocampus is the key region that plays a significant role in the memory function. So what I did is we took the MRI data from again the 43 ME/CFS and 27 healthy control, and estimated the hippocampus volume in ME/CFS as well as the healthy control. And interestingly, we found a significantly higher volume of hippocampus soft field in ME/CFS patients compared to the healthy control. But if you look at other kind of diseases, for example, Alzheimer's, multiple sclerosis, schizophrenia, what they are reporting is that they are seeing the increment in the volume, decrement in the volume of hippocampus. But in ME/CFS, we are just seeing the opposite. This is the increment in the hippocampus volume. And again, if we look at these COVID-19 patients from the Lu et al., what they have shown is they have again the significantly higher gray matter volumes in the hippocampus and other brain regions. So this also shows that, okay, ME/CFS patients and the COVID-19 patients have similar changes in the hippocampus and other brain regions. Next slide, please. Yes, and in this study, what we did is we try to see again, is there any changes in the cortical volume and the thickness in ME/CFS patients compared to the healthy control? And we collect the data from the 17 ME/CFS patients and compare to the 27 healthy control. And interestingly, what we show is that the caudal middle frontal region volume and the precuneus thickness were significantly reduced in ME/CFS patients compared to the healthy control. So you know that again, if you look at the symptoms, caudal middle frontal involved in the memory, again, precuneus region involved in the vision, in the light sensitive, and these are the symptoms in both ME/CFS and the COVID as well as the long COVID patients. So it makes sense. Okay, this might be the regions involved in those kind of symptoms appearing in ME/CFS, COVID, and long COVID. And another study, big study from the UK Biobank, where they collected the 41 COVID patients and 384 controls, and they are also seeing the reduced gray matter thickness in the COVID patients. So in the different brain regions. So what this MRI study is telling us that what we are finding from the ME/CFS is pretty much similar what the people have found in COVID-19. So this suggests that there might be this suggests that there is similarity between the ME/CFS and COVID-19. And next slide, Nat. And so this might lead us to the future research in the long COVID. So what are the MRI findings that we have shown in the ME/CFS is that we have seen the higher signal intensity in ME/CFS and the COVID-19 patients. DTI parameter, for example, axial and mean diffusibility that measure the axonal integrity and myelin loss, or lower in ME/CFS and COVID-19 patients. Higher volumes of hippocampus and the gray matter were observed in ME/CFS and COVID-19 patients. Cortical volume and thickness were reduced in ME/CFS and COVID-19 patients. Because of these similarities between ME/CFS and COVID-19 patients, what we are doing is now we are trying to implement all these findings from ME/CFS patients, and what we have got information from COVID-19 patients. Now we are further investigating into the long COVID patients. So we are collecting the data now, and we have written the manuscript. I am not showing the results here, but we have got a very promising results because of it's not I think because of confidentiality I can't show that results, but I can assure that what we have seen in the ME/CFS, we have seen that in the long COVID patients, and we'll be doing more and multimodal MRI study to confirm all these pilot findings into the long cohort study. So I hope this basic background from ME/CFS and COVID-19 patients from MRI will lead us the findings in the long COVID, similar findings in the long COVID patients. Next slide. Yes, then I would like to acknowledge all the our team at NCNED, all the funding agency, and all the international collaborators. Thank you.
Thanks so much, Kieran and Natalie. That was incredibly interesting and very detailed. We have another presenter tonight, Fabian Jaramillo, who was going to talk to us about Health Pathways update on long COVID. But in the interest of time, Fabian has agreed just to pass on those details, and we'll pass all of those on to you as soon as we can so that we can get to the question time just now. So thank you so much, Fabian. We had a lot of questions that were submitted prior to our event tonight, and of course most of those questions have already been answered. I wonder if our presenters could just all turn their cameras on again, please. One of the really interesting questions I thought was submitted around lung function testing in these post-COVID patients, where we are noticing a significant drop in FEV1 and FVC, particularly in pre-employment medicals. Rod, this might be a question for yourself. Where we are, excuse me, looking at mine medicals, cold board medicals, for example, in patients who have no comorbidities and they've recently had COVID, the deficit in their lung function testing can last for quite a long time. Has this been a statewide experience or experience from yourself in South Australia? And so, what are we going to do with those patients?
Thank you. Yeah, so the broadest response to that question and answer goes along with whatever part of the body seems to be affected by the illness is where you might end up with a specialty. So if it's a respiratory condition, then respiratory physicians can look at it. Some work coming out of Oxford from Richard Hobbs showed that the inhaled steroids, I think it was Symbicort was what he used. So looking at repurposed drugs, that was the only medication that I guess following on some of the work that showed that dexamethasone had some help in acute steroids. But the best advice I can pick up from what we've heard both in South Australia and following some of the other respiratory units that have been following up cases, actually to treat it like you would any other respiratory illness, if someone with COPD, and the inhaled steroids in Symbicort is shown with some overseas experience to have a specific benefit.
Fantastic. Graham, you wanted to add something to that? Graham, are you on mute? Sorry. Okay.
Right. Rod, we have a long COVID task group on the Gold Coast, which includes a respiratory physician who is well versed in long COVID management. Personally, Symbicort is probably the most effective product I've seen. I see a lot of microembolic damage, and even the Symbicort even helps there. But when you do their lung function, it is down 30% easily, but it does recover generally as we recover them. Sahan Bandara is the physician, and he talks about the residual fibrotic lung disease and diffuse alveolar damage, and there's secondary organizing pneumonia changes, and there's some terrible problems in the immunosuppressed one. But there's some great work from Denmark on low levels of surfactant in COVID. And this starts to get very tricky. Look, there is a way for us as GPs to tackle this. And I think your suggestion of Symbicort is awesome. Look, I'll pass on any information that anyone wants on any of the processes that's occurring.
Thanks, Graham. The next question, Matthew, might be for you actually. The term long COVID. Should we really be using the word long, considering that there is this ME/CSF process? Are we not quite at the point of saying that the patients with long COVID, of course, have ME/CSF? I think that was the take-home message from Kieran and Natalie. Can we move away from long?
I don't think anyone really likes the term long COVID, to be perfectly honest. I just think it's out there in the lexicon, and there's almost no avoiding it. We've tried to use, as I said in my presentation, COVID recovery, but you know, you go to the Lancet and long COVID is the heading of a lot of journal articles. It's just something that has that recognition factor, and unfortunately, unless someone can introduce a meme that goes viral and replaces it, I just think we're unfortunately stuck with it, to be honest, as much as I'd love to change it to something else.
You might have the resources there in Queensland Health to develop such a meme. That's fantastic. We did have a question about particularly visual resources to use with patients, which might already be available on that website that you've alluded to. So we'll be able to go back and have a good look at that. What then would be the baseline investigations for some of these patients? We talked about a baseline functional assessment and then a gradual return to full activity. Graham, I think, mentioned the D-dimer. Is there anything else that's particularly useful at this stage of the game when we're having excluded other potential causes of this fatigue or persistent shortness of breath or persistent pericarditis, whatever our patients might be experiencing? What do we need to do first?
Just start briefly, Rod, here, is that it's about finding something that you think you can measure and then monitor. And in South Australia, there's at least half a dozen different things like the Epworth Sleepiness Scale, if you want to use that. Find a scale that you've got that measures whatever people are complaining of, and then encourage them to monitor that. Because if you've got a test that you can monitor, you can show their recovery, and that fits with the positive sort of interaction and reassurance that they'll get better. So that's broadly how we've approached it, and seems to be choose a scale that you can monitor, measure, and use to help people manage their recovery.
Anything to add from the rest of the panel? No, excellent. Thank you so much, Rod. Natalie, go ahead.
I will just say that we have many long COVID patients reach out to us in research, and they have actually provided these scales that their GPs have recommended, and it also does help with research. So I'm just putting that out there.
Right. Okay.
Can I add? Oh, whoop, Alyssa.
Yes,
Sorry, I'm me again. Right, we'll start off with your normal stuff. Do your D-dimer, please. Though I must admit there's some work coming out of Griffith Research, which you haven't heard about. They've gone back and looking at their chronic fatigue patients, and they're picking up elevated D-dimers. Fairly important, low complement C3 is a major prognostic measure. Lymphocyte subpopulations, another one. If you have CD8 lymphopenia, you have problems. Please check ANA, TSH, complements. Tryptase, very important before you start mast cell blockade. The normals are wrong. A normal is around 3. Low is very concerning. We have a subgroup in which we're trying to get DNA funding for, which have no CRP at all, which have very low C3s and very low tryptases. What the hell is going on? We are trying to work that out with the DNA.
Yeah,
Serum ACE is, sorry, I'm adding a couple. You got to add, if you've got chest problems, you've got to do a serum ACE. And you've got to do a troponin when it's appropriate. Beta-2 microglobulin if there's any instability. Lipase for abdominal pain. Your ApoE4 is mandatory in cognitive impairment. Now I'll shut up.
Thanks, Grant. I think it's probably important for us to remember that all of those studies are we probably need a really good evidence base before commissioning such an enormous number of studies, which is going to be enormously expensive for Medicare. As we've already mentioned tonight, we've already been in the newspaper enough with Medicare rorting, which of course testing is not doing, but we do need to be cautious about what we're ordering for our patients, or if we're ordering privately, it will be enormously expensive for them. There was a question here that I think possibly is for Matthew, is around children. And I only say for you because of your substantive position with Children's Health Queensland, but are we seeing a lot of long COVID in children, and are they presenting differently? Are we managing them differently?
In short, no. No to are we seeing much in children? There's been quite a few systematic reviews done here, and one recently that I had it in my slides, but I took it out at the last moment. And their finding was that the most common symptoms, and I can't remember how many they were looking at, but it was over 10 of the common long COVID symptoms. They followed these kids up, and they were sort of in the order of above between 5 and 18 from memory. They found, and it had a control, they found that there were no differences in the reports of symptoms. And in fact, some of the most common long COVID symptoms, the kids that were not COVID infected were over-reporting or reporting more of these more common symptoms than the kids who'd had COVID. So generally speaking, most of the reports I've seen have found that the difference between the control cohort and the COVID positive cohort in children it's very, very minimal.
Fantastic. All right, well, we might wrap it up there. We've just gone a fraction over time. I'd like to thank the primary health networks of Queensland, particularly QPHN, my PHN, who are hosting tonight, and all of the presenters for your time and your expertise tonight. It's been a really interesting and enjoyable webinar, and I hope that all of our listeners today have found it equally useful. Please continue to send in your questions through our chat function, and we'll be able to respond to those in due course. Remember to pop in the presenter who you think would best respond to your question so that we can direct it to them specifically. And to everybody else who's with us tonight, thank you very much. It's been a pleasure.